everyone. We did our project on the role of calcium and vitamin D in the prevention and treatment of stress fractures in young female athletes. Alright, so first, what is a stress fracture? A stress fracture is essentially a small crack in the bone. It normally occurs after prolonged periods of activity that fatigue the muscles surrounding the area. Those muscles can no longer absorb the shock of the forces, which leaves the bone more vulnerable to cracks. It is normally diagnosed when persistent pain is noted, even when the person is non-weight bearing, when there's local tenderness over the affected bone, and when there's local swelling around the affected area. It can be tested by the hop test. In this test, the patient hops up and down on the affected limb several times. If a large amount of pain is felt in a localized area, then it is a positive test. Other possible tests include the hyperextension and fulcrum test. Stress fractures can be classified as either high or low risk. High-risk fractures likely progress to complete fractures and require the person to be non-weight bearing. Low-risk fractures normally respond well to non-surgical management and allow for unassisted weight bearing. It is often treated in two phases. The first phase is all about pain control. So this includes ice massage, modalities, and pain medication. No sports activities should occur during this time. Phase 2 begins once the person is pain-free for 10 to 14 continuous days. They can begin by running every other day. Then after those first 2 weeks, activity can be progressed over the next 3 to 6 weeks. There is a large variance in return to sport time. A timeline anywhere from 5 to 19 weeks is recommended for tibial stress fractures depending on its severity. Young female athletes are at a higher risk for stress fractures. According to one study, there is a 9.7% incidence of stress fractures in young female athletes, compared to 6.5% in their male counterparts. For young female track and field athletes, the one-year incidence rate ranges from 8.7% to 21.1%. Since track and field is a high-impact sport with a lot of external loading, there tends to be a higher incidence in these athletes when compared to athletes participating in other lower-impact sports. So now, how does calcium and vitamin D factor in? It was found that a higher intake of calcium, dairy products, and skim milk is associated with lower rates of stress fractures. For each additional cup of skim milk per day, there was a 62% reduction in stress fracture incidence. This essentially suggests that increasing your nutritional intake of calcium and vitamin D reduces your risk for stress fractures. However, it has been found that young female athletes often do not consume the recommended amount of calcium and vitamin D. In a study of 18 female athletes, 15 had vitamin D levels lower than recommended, and 13 had calcium levels lower than the optimal levels. Of 72 female athletes, about a quarter had calcium levels less than the estimated requirement for calcium. So why is adequate calcium and vitamin D consumption important for young female athletes? So just at baseline, young female athletes are under 30 years old and have not reached their peak bone mass. In order to simply reach their peak bone mass, they need a positive calcium balance to gain bone. In addition to this, there is an additional external loading for athletes. This increases their body's calcium demands even further. For example, intense training helps increase bone mass by stimulating bone formation. This process requires calcium. Microfracture repair occurs through the process of remodeling, which also requires calcium. During intense training, about 247 milligrams of calcium can be lost through the skin. So essentially, this extra training increases the calcium demands for these young athletes. However, based on several studies, young women's nutritional intake often don't meet these calcium and vitamin D demands. The general concept of having a high risk of developing stress fractures is that if loading is greater than the body's ability to form new bone, the net turnover is increased and the bone will be temporarily weakened.
So Crystal mentioned vitamin D and calcium, and now we're going to talk a little bit more about the physiology and the role in bone health. So generally speaking, calcium and vitamin D work in tandem to build and maintain healthy bones. Calcium does the building and the maintaining, and vitamin D helps the body absorb calcium. A little bit about calcium. It's the nutrient most commonly associated with bone formation and metabolism. And when it's deposited into the organic matrix of the skeleton, it gives bone tissue structure, strength, and elasticity, which is really important for normal movement and exercise. If the body removes more calcium than it replaces, bones will become weak and more prone to breaking. So a little bit more about the interplay of calcium and vitamin D. Vitamin D is going to suppress PTH, which is a hormone that stimulates the body to take calcium from the bones. So instead, vitamin D will also stimulate the absorption of calcium from the intestines instead of the bones. This allows calcium to stay in the bones, maintaining strength and structure. So there are two main forms of vitamin D in the body. There's vitamin D3, which is synthesized in the skin after exposure to sunlight or ultraviolet light, or also obtained from nutritional sources like fatty fish. There's also vitamin D2, which is obtained by irradiation of plants or plant materials or foods. So now we're going to look at the pathway and mechanism of vitamin D. Vitamin D is hydrolyzed into an active metabolite 1,25-hydroxy-D3. For sake of ease, we're going to refer to this as the active metabolite. Hydrolysis occurs first in the liver and later in the kidney. The active metabolite will enter the cells and bind to transcription factor VDR, which is located in the osteoblasts. When the active metabolite binds to VDR, it will promote the differentiation of osteoblasts and regulate the production of proteins such as collagen, alkaline phosphatase, and osteocalcin, which are thought to be important in bone formation. Osteocalcin is a calcium-binding protein, which means that it mediates calcium absorption in the intestines. Osteocalcin is activated by vitamin K2 and causes calcium to bind in bone tissue, which provides strength to the bone tissue. So here we just have a visual diagram talking about the pathway that we've already discussed, and the other half is going to be pathways we'll discuss later in our presentation.
Next, I'm going to be going over the process of when the active metabolite vitamin D3 is deficient or low in the body. So I'm going to give you kind of an overview first. And so as Aylin touched on, the active metabolite vitamin D3 can affect osteoblast transcription positively or negatively, meaning it regulates both bone formation and bone resorption. So as Aylin had talked about, the positive transcription is when it regulates whether the production of collagen, alkaline phosphates, and osteocalcin mediates the absorption of calcium through the intestines, and this all occurs when there are sufficient levels of calcium and vitamin D. When there's negative transcription, or when you're vitamin D3 deficient, that's when the active metabolite vitamin D3 is low. So the vitamin D receptor transcription has a negative effects by regulating calcium and phosphate levels through absorption from the bones instead of the intestines. And that is how it replenishes those calcium levels in the blood. What regulates this whole process when there's negative transcription? The parathyroid hormone is what does that. So when the active metabolite vitamin D3 is low, the parathyroid hormone is activated. Thus, the parathyroid hormone maintains calcium levels by increasing calcium release from bones, inhibiting calcium formation, and conserving calcium from urine, even at the cost of skeletal integrity. This is important because when there's bone resorption and remodeling, the bone is in a weakened state. And if the body has to replenish those calcium levels by also performing further bone resorption, it weakens the bone even further, which can lead to those stress fractures. Next, we're going to dive a little more into what the exact mechanism of the parathyroid hormone and how it exactly regulates the calcium release from the bones. Just to review, if there's normally occurring the active metabolite vitamin D3 concentration is high, then calcium levels are high and the parathyroid hormone is suppressed. So if you look to the figure on the right, you can see that over the kidneys, you can see the active metabolite vitamin D3, and there's a line connecting to the parathyroid hormone, and when it's high, it has a suppression, so it has a negative feedback on that parathyroid hormone, and there's a negative sign with that line. when there's a decrease in the active metabolite vitamin D3, the parathyroid hormone is stimulated. And so this means that the parathyroid hormone, as you can see on the figure on the right, there's a line connecting from the parathyroid hormone to the kidneys, and you can see that it's affecting the 1-alpha hydroxylase. This is where the parathyroid hormone is suppressed when the vitamin D levels and calcium levels are high, meaning that the 1-alpha hydroxylase in the kidneys has decreased activity and functioning. So when there's low dietary calcium and phosphate, and there's low levels of the active metabolite vitamin D3, the parathyroid hormone stimulates the transcription of the enzyme in the kidney. 1-alpha hydroxylase is also known as cytochrome P450 and is encoded by CYP27B1 gene, or simply known as the 1-alpha hydroxylase. It's located in the proximal tubule of the kidney, and as Aylin had mentioned prior, the role of that enzyme is to hydrolyze the 25-hydroxyvitamin D3 to the active metabolite form 1,25-dihydroxyvitamin D3, also known as calcitriol. And this all occurs in the kidney. So, in the proximal renal tubule, you have that 25-hydroxyvitamin D3, and it's hydroxylated at the position of carbon 1 of the A ring, resulting in the hormonally active form of vitamin D, 1,25-dihydroxyvitamin D3, which is that active metabolite form is responsible for most of the biological actions of vitamin D. So just to summarize, the parathyroid hormone regulates vitamin D pretty tightly, and it does this by stimulating the 1-alpha hydroxylase enzyme, causing the synthesis of vitamin D3 active metabolite form, which causes the calcium levels to increase from resorption of the bones. Next, I'm going to give an overview of the bone remodeling phases. The bone remodeling cycle is composed of 4 sequential phases. We'll go further into all of these phases later on in the presentation, but we just wanted to give an overview of the process to give you an idea. So the first phase is activation, where you have osteoclast precursors are activated and bind to the bone matrix to form sealing zones. This causes osteocyte apoptosis. The second phase, you have resorption, where you have breakdown of the matrix and the osteoclast digest the organic matrix. They are activated to do this through the Rankel cytokine. We will go further into this later in the presentation. The third phase you have is reversal, where you have bone resorption transitions to bone formation. And the fourth phase is formation of new osteon. It is important to note the various phases of the bone remodeling because for the remodeling to occur, it has to break down parts of the bone to remodel it. And that's why it's important for the calcium and vitamin D levels to be sufficient, because if there are calcium and vitamin D levels are low, then it has to resorb even more bone to maintain those levels, and that can cause problems such as stress fractures and increase your risk for those. So the question is, how much is too low? Several studies have cited various levels that they marked as the cutoff point for having too low of the active metabolite vitamin D3. One study quoted that the concentration of less than 40 nanograms was the cutoff point. Another had mentioned 30 nanograms as their agreed upon cutoff point for having deficient levels of vitamin D3. Another study had stated that 26 nanograms should be the cutoff. And another study from the Mayo Clinic had said that optimal levels of vitamin D was if you had greater than 20 nanograms. An interesting thing to note is that one of the studies, the study that rated or said 30 nanograms should be the cutoff point, they used that number based on because that's when they saw that if you had greater than 30 nanograms of vitamin D3 active metabolite, that is when the parathyroid hormone was suppressed. And they saw that if you were below 30 nanograms, that's when the parathyroid hormone would begin to be activated. And that's how they based on their level. But more research needs to be done to determine what level is actually appropriate and what levels we should be recommending as deficient or sufficient for future patients. So next we're going to discuss osteoclastogenesis. But first let's review. So you have the parathyroid hormone, which regulates vitamin D3 active metabolite. It does this via stimulating the transcription of enzyme 1 alpha hydroxylase. This causes the synthesis of vitamin D3 active metabolite formation, and the active metabolite is then transported via a megalin-cubalin complex. This is produced by the parathyroid gland. And where does it get transported to? It is then brought to the osteoblasts. The active metabolite binds to the vitamin D binding protein of albumin, and that is how it's transported. When it binds to the vitamin D receptor, it heterodimerizes with other nuclear hormone receptors, in particular the family of retinoid X receptors. So when bound to the 125 dihydroxy vitamin D3, it regulates gene transcription. So you can have positive, where calcium is absorbed through the intestines, or you can have negative, where calcium is taken from bone resorption. And when a protein heterodimer is formed, it's formed by two different proteins. So in this case, the vitamin D receptor and the retinoid X receptors. So when the active metabolite binds, osteoblasts then express two cytokines. That is Rankel, receptor activator of nuclear factor NF-κB ligand, as well as MCSF, macrophage CSF. Cytokines, a large group of proteins, peptides, or glycoproteins that are secreted by specific cells of immune system, are a category of signaling cells that mediate and regulate immunity, inflammation, and hematopoiesis. The important one to note is the hematopoiesis. So, the precursors are taken from hematopoietic tissues, essentially stem cells. They are taken into the blood. They're done this via S1P and S1P receptors, and they are the ones involved with bringing those precursors into the bloodstream. From there, osteoblasts hone in those precursors to bring them to the osteoblast sites. Those precursors express two receptors, RANK and CFMS. Those receptors are important because they accept the two cytokines that osteoblasts express, Rankel and MCSF. The other component that also has a rank receptor is osteoclasts. So as you can see on the figure on the right, osteoblastic cells express Rankel and MCSF cytokines. The osteoclast precursors have those two receptors to accept both of those. Osteoclasts, in general, adult osteoclasts, just have the rank receptor, but they also are activated when osteoblastic cells express Rankel. So, to start how an osteoclast precursor becomes an activated adult osteoclast, when those two cytokines bind to those two receptors on the osteoclast precursors, they differentiate into pre-osteoclasts. Pre-osteoclasts are mononuclear. They are mediated by DC stamp, and this process is still fairly unknown, but they have recognized that DC stamp helps mediate pre-osteoclasts, then fuse together and to make multinuclear osteoclasts. Once they are osteoclasts, they have that receptor, and so when the osteoblastic cells express Rankel, it can bind to the rank receptor on them and they become activated. Once activated, osteoclasts can lead to that bone resorption. As we discussed in the previous slide, the bone resorption is when those osteoclasts bind to that bone matrix and forms those sealing zones to break down the matrix in the bone. Now just to review all together, so we start with low active metabolite vitamin D3. The parathyroid hormone is stimulated by the low levels. This stimulates 1-alpha hydroxylase to synthesize vitamin D in that kidney, and the osteoblasts, the vitamin D then is sent to the osteoblast where it binds to the vitamin D receptor, and then it releases the RANKL and MCSF. The RANKL and MCSF bind to the osteoclast precursors, and those osteoclast precursors then differentiate into pre-osteoclasts. Those pre-osteoclasts fuse together to make osteoclasts, and then the osteoclasts are activated when the RANKL binds to them. And then you have the bone resorption.
Now that we have an understanding of how calcium and vitamin D affect bone health, let's dive into how, as PTs, we can help patients with a stress fracture and prevent stress fractures. First is with a proper evaluation, you want to make sure to get their full and entire history. Although most stress fractures come from insidious onset, they tend to be triggered by a change in the load of training. A study conducted on NCAA female athletes found that the athletes experience the highest occurrence of stress fractures during their preseason, which is when the athletes are participating in double days to try and get into the best shape, but may not be getting the proper rest and nutritional intake to allow their bones to recover. It is important with females to screen for what is known as the female triad. This screening consists of getting information on the patient's dietary changes, any weight fluctuations, and their current menstrual status, because all have an effect on the amount of calcium and vitamin D levels in the body. Along with getting their health and history, it is also important to get their family history, because a heritability factor of 50 to 85% has been linked to stress fractures depending on the anatomical location of the injury. When beginning to treat your patient with a stress fracture, it is important, as Crystal noted, to start by reducing the patient's activity until no longer in the acute inflammatory phase. When they progress out of the acute phase, you can then begin to assess the biomechanical and physiological impairments. For a runner or military recruit, you may need to implement a change in their gait that allows for a softer heel strike to decrease the force on the tibia. Similarly, with gymnastics, basketball, and cheerleaders, you will want to teach them proper landing techniques. To assist in your treatment plan, you may also want to use external agents and modalities. A study on shock-absorbing shoe inserts were shown to be effective in reducing the occurrence of lower extremity stress injury in young female military recruits. Another helpful device may be a pneumatic brace, because they were shown to significantly reduce the length of the injury. Finally, with all patients, we want to help prevent future injuries, and that is done by a balance of not too much, but not too little of both exercising and diet adjustments. First, a study found that it is important to start bone strengthening from a young age. Bone strengthening consists of dynamic weight-bearing exercises that are moderate to high in load magnitude, short in duration, and non-repetitive in load direction. Doing this form of activity 3 days a week was shown to improve the bone mineral density in adolescents. From this studies on bone strengthening in children, researchers were able to conclude that there is A-level evidence supporting the claim that activity has an effect on bone mass. They stated that children and adolescents who were physically active at the ages of 8 to 15 years old had an 8 to 10% increase in bone mass at the ages of 23 to 30, when compared to the group who was not active. Although it has been shown how helpful activity it is also important to warn patients and parents on the effect of overtraining. One study found that girls who engage in 8 hours or more per week of activity were about twice as likely to develop a stress fracture than those below the 8-hour threshold. The activities with the highest level of injury included running, basketball, and cheerleading or gymnastics. Continuing on with patient education.
We as PTs only have a basic knowledge of dietary needs, but we can still encourage our patients to make sure they are meeting their own dietary requirements of calcium and vitamin D. One study found that active females should be consuming 1,000 milligrams of calcium and 300 to 2,000 international units of vitamin D. And if you have a patient who is amenorrheic, they may require an additional 500 milligrams a day of calcium. But make sure when discussing dietary needs to refer the patient to have a more in-depth conversation with a dietitian. The evidence on the need for calcium and vitamin D shows that among adolescent girls participating in high-impact activities, vitamin D intake is inversely proportional to stress fracture risk. So the lower the amount of vitamin D the patient has, the higher risk they have. It was also shown that an increased consumption of calcium and vitamin D increased the circulating calcium and decreased the expression of wrinkle, which leads to a decrease in the bone reabsorbing activity, as we discussed earlier. Finally, although there is evidence on the importance of calcium, you want to encourage your patients to meet their daily requirements through a normal diet to reduce the need of supplements. If a patient does need to use a supplement, make sure to educate them on the risk of kidney and cardiovascular disease that can occur with over-supplementation. Now for some key take-home points. First is that young female athletes are at an increased risk of stress fractures, partially due to the imbalance of calcium demand and calcium vitamin D supply. If there is sufficient vitamin D, then calcium levels are maintained by absorption through the intestines. However, if vitamin D supply is low, then the parathyroid hormone levels will increase and osteoclastogenesis occurs, which increases bone reabsorption, leading to weaker bones that are more prone to breaking. The key to strong bones is balance. Encourage bone strengthening exercises, but with moderation. More than 8 hours of high impact activity a week can actually lead to an increased risk of stress fractures. So now you can pause and take this little quiz for yourself. The first question is, how does intense training increase calcium demands, and why are female athletes at a higher risk for developing stress fractures? Second, what are 2 sources of vitamin D? Third, at what concentration, low or high, does the active metabolite vitamin D3 stimulate the parathyroid hormone? And finally, what is the first step in treating a patient with a stress fracture? That concludes our presentation. We hope you enjoyed it. And for reference, the next few slides are just our bibliography. Thank you, guys.